A previously well 25-year-old female was brought to the emergency department by her boyfriend because of progressively blurred vision. Eye examination reveals loss of horizontal gaze, intact convergence, and nystagmus. A clinical diagnosis of multiple sclerosis is made, and the patient is started on a course of corticosteroids. What is the most likely etiology for her eye examination findings? Answer choice A, loss of reticular formations. B, loss of frontal eye fields. C, loss of bilateral MLF. D, loss of cranial nerves 3. And E, loss of cranial nerve 6. Now take a moment to come to your own conclusion. Now let's go through the question characteristics that we're dealing with here. Now, what's the subject we're talking about? This is a multiple sclerosis patient, so this is a classic neurology question. Now, this question is what we call a two-step question. You have to make one conclusion first and then take another deeper step to get to the right answer. And in this question, the STEM is required to come to the conclusion. We have to rely on the details in the clinical vignette. Now, let's walk through the question. The first thing we need to do is determine the type of eye disorder that the patient is experiencing. Well, in the question stem, we learn that the abnormal eye movements that we hear about are blurred vision, loss of horizontal gaze, and nystagmus. Well, when it comes to blurred vision, this is commonly caused by disorders of the lens of the eye. But the fact that in this patient there also is loss of horizontal gaze suggests that there's actually misalignment of the eyes being the cause of the blurred vision. Now, this patient has intact convergence, that is, adduction of both eyes towards the nose. Now, this confirms that both medial rectus muscles are well innervated and not paralyzed. Thus, there is no cranial nerve 3 palsy. And the fact then that the combination of intact convergence and loss of horizontal gaze actually suggests that there's a disorder in the conjugate eye movements, with the most likely diagnosis here being internuclear ophthalmoplegia, or INO. Now, once we figure that out, we need to go one step deeper to determine the anatomical structure that's affected in this eye disorder, or as we call it in neurology, we need to localize the lesion. Now, conjugate eye movements require simultaneous contraction of the oculomotor muscles in both eyes that are innervated by the ocular motor nerve, cranial nerve 3, and also the abducens nerve, cranial nerve 6. Now, transmission of integrated information from upstream gaze centers to these nerves occurs via a white matter tract called the medial longitudinal fasciculus, or also the MLF, on each side of the brainstem. Now, this is a structure that's affected in internuclear ophthalmoplegia. We have now just localized the lesion. Now, in patients that have multiple sclerosis, they have generalized demyelination of white matter tracts, the MLF being a white matter tract, and then they thus have internuclear ophthalmoplegia. In fact, in multiple sclerosis, the internuclear ophthalmoplegia is usually bilateral in these MS patients. Thus, the answer choice that's correct here is answer choice C, loss of bilateral MLF, leading to the eye findings in the exam. Now let's discuss some high-yield facts that we can learn from this question. Now, multiple sclerosis causes demyelination of white matter tracts in the brain and also the spinal cord. Due to the involved generalized lesions of the central nervous system, signs and symptoms of MS can really widely range from one patient to another. We can see double vision, muscle weakness, trouble with sensation, trouble with coordination, and even mental cognition disorders. Now, MS usually has what we call the relapsing and remitting form, in which patients have isolated attacks that are worse and then get a bit better. Another form, less common, is called the progressive form, in which patients just continuously get worse and worse. They don't have these acute flares. Now, multiple sclerosis is typically diagnosed in young patients, and more highly there is a prevalence in females than in males. Now, the underlying cause of multiple sclerosis is unknown, and there unfortunately is no cure. But there is symptomatic and disease-modifying treatments that have proven effectiveness. Now, another high-yield topic is internuclear ophthalmoplegia. Now, this is a disorder of horizontal conjugate lateral gaze in which the affected eye or eyes cannot adduct. It's caused by a lesion to the MLF, or medial longitudinal fasciculus, in the brainstem that transmits integrated information from upstream gaze centers to the oculomotor nerves. In MS patients, very important to know, the lesions to the MLF tends to be bilateral. Now, the MLF is a white matter tract on each side of the brainstem that coordinates abduction of one eye and adduction of the other eye to produce conjugate horizontal gaze. Now, the structures the MLF connects are known as the ipsilateral nucleus of cranial nerve 6, which controls abduction, the contralateral nucleus of cranial nerve 3, which controls adduction, and the ipsilateral paramedian pontine reticular formation, also called the PPRF. Now, lesions here result in an impaired adduction in horizontal lateral gaze, but convergence will remain intact, which we also saw in this patient's clinical presentation.